spoke with Dr. Aditya Bardia, a lead investigator on the EMERALD trial, and he told us a little bit about the gap that the EMERALD trial was seeking to fill for patients.
Yeah, absolutely. For a patient with metastatic hormone receptor positive breast cancer, the standard was endocrine therapy plus a CDK4/6 inhibitor first line. And in the second line setting, the drug that was used was fulvestrant, which had modest activity in the post-CDK4/6 setting. And also patients were getting the medication as an intramuscular shot. So it was very inconvenient given that it's given as a shot twice a month for the first month and then once a month. So the unmet need was a better endocrine option in this setting. And second, something that's oral. So the EMERALD trial was designed to address this unmet need. Can we bring an oral and more effective endocrine-based options in the post-CDK4/6 setting? So patients with metastatic ER-positive breast cancer who had received prior CDK4/6 inhibitor were randomized to elacestrant, an oral selective estrogen receptor degrader, versus endocrine therapy of physician's choice, which was predominantly fulvestrant in this setting. The trial had two primary endpoints: progression-free survival all comers and progression-free survival in patients with detectable mutations in the estrogen receptor. And we can come back to this point. The reason this was designed this way was we know in the second line setting, the mechanism of endocrine resistance is heterogeneous. There are a subset of tumors that are still ER pathway dependent. There are a subset that are not. So can we identify the tumors that are ER pathway dependent? And the use of ESR1 mutations was a surrogate marker, because if a tumor has estrogen receptor mutations, it's likely still being driven by the estrogen receptor. And so that was an important endpoint in this clinical trial. In general, elacestrant is very well tolerated. The rate of treatment discontinuation was very low with elacestrant in the clinical trial. The most common side effect that's seen is nausea, but it's usually low grade, not enough that you need an anti-nausea medication, but more like if some patients take ginger or some other strategies, or with food, and usually it's not a problem. It can also cause upper GI discomfort. So the use of an antacid or proton pump inhibitor, or with food again, could be considered. Outside of that, it does not have major side effects, not much hot flashes or muscle aches, joint aches. And given that it's oral, does not have the inconvenience of the intramuscular shot.
The results of the EMERALD trial were positive. In patients with an ESR1 mutation, 26.8% of patients still had stable cancer at 12 months, compared to only 8.2% of those who received the standard of care. This is incredibly exciting because it's the first new hormone therapy to be approved in more than 20 years. And it offered a pill option to combat the significant problem of resistance to hormone therapies. After patients with metastatic estrogen receptor positive breast cancer receive their first line of therapy, some patients' tumors still rely on estrogen to grow, but some do not. If you're interested in learning more about how estrogen and the estrogen receptor drive tumor growth, you can check out our video linked below.